So it's really a pleasure to be here with my friends and meeting all the new young people who are interested in nephrology, and I think we'll have a lot of fun. Um, so, okay. So I'm going to try and convince you how we can improve kidney outcomes in lupus nephritis. These are my disclosures. I work with a lot of the companies and work with them in developing drugs that are used in lupus and other diseases. I hope that you'll find this is not a conflicted talk. I'm going to just list the investigators here. These are all folks from my lab and from my collaborators and others who have contributed some of the primary data to this. And I've listed, you could say unusually, a company here. I work closely with Genentech in the development of obinutuzumab, but I have extra data that you haven't seen that will be sort of fun to look at. Okay, so how can we improve outcomes in lupus nephritis? And the first thing I'll tell you is to diagnose and treat earlier. So this is from a review article we put together, but what we did was we scoured the literature, including our own publications, to look for patients who had biopsies prior to the usual clinical criteria that we sort of made up to decide when to biopsy somebody with lupus nephritis. And you can see there's quite a few biopsies. They're listed at the far left. It's a little bit cut off. The proteinuria levels are all under 500 milligrams a day, which is sort of the threshold KDIGO says to do a kidney biopsy nowadays for lupus nephritis, and some are quite low, 250 milligrams or 300 milligrams. Some of them had glomerular hematuria, so glomerular hematuria, acanthocytes, etc., and some were first biopsies, some weren't listed. But what I want to show are the two highlighted boxes in yellow. First of all, when you do the biopsies in these patients, you can see that class 3 or 4, so proliferative lupus nephritis, or class 5 histology, was present in a not insignificant number of patients. So in other words, patients with ostensibly no clinical signs or symptoms of severe kidney involvement actually have histology consistent with class 3, 4, or 5. And I call it actionable, or at least actionable histology, something that we might want to think about. Importantly, and you can see what the activity indices were, but importantly, these are patients with lupus who've never had kidney manifestations, and yet when we do the biopsy, you can already see that some didn't have very high chronicity levels, but others are already showing chronic damage. So the point is that we're missing the early start of the disease, and when we miss the early start of the disease, we tend to get damage accumulating even though we don't see that clinically. So we're working with an NIH project. It's called the AMP-AIM project, but this is with several folks around the country. And we're enrolling lupus patients with no history of lupus nephritis, and they have a UPCR of 250 milligrams to less than 500 milligrams. Now, the way we got it through the IRB was they had to have another predictor of lupus nephritis, and we were pretty loose here. Non-white race, low serologies, or a double-stranded DNA, or an active urine sediment. The patients all had good kidney function defined by GFR. They weren't taking any of the big gun immunosuppressive therapies, and they had to be on 10 or less of prednisone a day. So a fairly clean biopsy in terms of medications. And we've recruited 39 patients so far, and I've listed what we found on the examination. Interestingly, there was class 3, 6 of them had class 3 histologically, and a bunch had class 5, which is remarkable. Almost no proteinuria with class 5 lupus nephritis, go figure. And then about 14 of them had no LN, and I'm going to focus a little bit on the no LN. That's no LN histologically, but is that the whole story? So about 64% had lupus nephritis and 44% had histologically concerning lupus nephritis. And we'll talk a little bit about the no LN biopsies. So This is from single-cell RNA-seq of the fresh frozen tissue, and this is spatial, and we're using the Xenium platform. These are all transcriptomic data. The control tissues here are pre-implantation kidney biopsies for transplant, living donor biopsies. So that's about as good as it gets, although the KPMP is actually biopsying you guys, people like us, that they volunteer to do a kidney biopsy. Sort of not sure I would do that, but anyway, even though I tell patients it's safe. But you can see that as you go from control, most of the leukocytes are myeloid cells. There's a few T cells in normal tissue, plasma cells, a few neutrophils. I don't know why. And then you see that this actually shifts as you move from no LN, the biopsies I just showed you, to what I'll call early LNs. So these are the early patients that I was just showing you. And you see an accumulation of T cells in the kidney. And we actually see a similar sort of thing confirmed by spatial transcriptomics. Healthy controls, not very much going on in terms of B cells and plasma cells, and the same thing with T cells. And you see as you go from LN or you go to no LN, in LN, you see an accumulation of cells. And so we decided to look at some of the molecular underpinnings of this. And we did transcriptomic profiles of the kidney T cells that are isolated from the fresh frozen tissue. And this is all a single cell RNA-seq. And this is T cells in the no LN patient. And these are T cells in the LN patients, okay? These are volcano plots, and they're compared to control. And the point I want to make is that when you start to see what's upregulated, what's being expressed in these T cells, you can see that a lot of things are being turned on. So this means it's elevated. This means it's lower than control. A lot of things are being turned on, and I've highlighted the interferon signature. These are all interferon, type 1 interferon genes that are being turned on. And what's really remarkable is you're seeing something in the no LN patient that's very similar to what you see in the patients that now have histologic lupus nephritis. Okay, and you can do the same thing with the intrarenal myeloid cells. And again, I'm emphasizing the interferon signature. Now, why am I emphasizing the interferon signature? As you all know, patients with lupus have a very high level of type 1 interferon related gene activity, and that's been shown in multiple investigations. And here we're seeing this very early on before we have clinical lupus nephritis. And, you know, one of our collaborators said, well, who cares? I mean, you know, lupus itself is a high interferon state, so what do you expect to see in the kidney? But let's think about that a little bit more as we go forward with this. Yes. If you go back to the slide, the scale even is even higher in the non-lupus nephritis. Yes. You mean that there's more there? I think so. I'm gonna throw some. Okay. I don't know the answer, the real answer. You know, we're just doing this stuff now, but it's interesting that some of the things in the no lupus nephritis seem to be, I'll use the word worse than the lupus nephritis. And then something matures over time. Exactly. And yeah, well, these are fold changes, but your point is correct with the cells as well. There seems to be a difference, and some of these actually look to be worse in the no LN patient. So again, keep that in mind. Okay, this is the type 1 interferon signature, and this is really hard to read, but this is going from infiltrating cells to finally talking about effects or what we see in the components of the kidney, the renal parenchymal cells. So podocytes and tubular cells, et cetera. And what you see is virtually no interferon signature in the control tissue, which is sort of what we would expect. This is the class 1 and class 2 patients that were early in the disease, and the interferon related genes are being upregulated. Mostly, these are T cells, these are myeloid cells, these are B cells, mostly in the infiltrating cells. And then as you progress to class 3 and class 5 patients, you see this explosion of tissue cells that are expressing interferon. It's almost like the interferon signature spreads to the renal parenchyma as things get more lupus nephritis looking. And then this is, I think this is really a cool slide. I've never done spatial transcriptomics before, but this is a spatial look at the kidney. You can see that we identify glomeruli, tubules, blood vessels very readily. And this is what the glomerulus looks like as we focus in on it. But I want to focus on this particular panel. And what this is the interferon signature within the glomeruli. And you can see that very little is going on in the control tissue, and very little is going on in some of these patients with lupus, but no lupus nephritis. But then as you come across this way, you start to see that other patients with lupus, with no lupus nephritis, start to develop a larger amount of cells in the glomeruli that are expressing the signature of type 1 interferon. And then, of course, this is what it looks like in the LN patient, so much worse. And so how do I think about this? So it's clear that the kidney within the lupus milieu, which of course you know is a systemic disease, seems to have a brewing inflammatory signature, even in the absence of frank lupus nephritis that we see clinically, or even histologic evidence. And maybe this is the way lupus nephritis sort of revs up in patients with lupus. I think the transition from no lupus nephritis to subclinical lupus nephritis seems to be accompanied by an increase in intrarenal T cells, which is sort of interesting because we don't think much about T cells in lupus very often, and all of the rest of the therapies I'm going to show you are targeting B cells. And we can talk about that in the end. But and the type 1 interferon signature really spreads from the myeloid cells and the lymphocytes to the other parenchymal cells of the kidney. So now I'm gonna bear with me. I'm gonna go off on a tangent here because I know a lot of you are clinicians. Do you guys have access to anifrolumab for lupus? Yes. Okay. Good. Okay. So I've been working with anifrolumab, and this is not the first rodeo we've had with interferon in lupus. And I guess there's some rheumatologists that might be here, or there's some on the line. It works really well for skin disease, and it's approved for extrarenal lupus, and we're studying it in lupus nephritis now. But the results of the anifrolumab study were pretty unremarkable. I'll just say modest in the phase 2 anifrolumab study. This is high dose anifrolumab, placebo, and low dose, and these are complete renal responses from the phase 2 trial at the end of 52 weeks. And you can see that, between the placebo and the high dose anifrolumab, there's not a huge increase in complete renal responses, and it did not reach statistical significance. And then this was continued onward for another 12 months, and patients from the original study who had achieved at least a partial renal response continued on the drug. And you can see that it's rather underwhelming at this point. So I'm just wondering whether or not we're using an interferon drug, which I thought was going to be super and work really well in lupus and lupus nephritis, especially if we're using it too late in the course. When the entire kidney is exploding with interferon signature, maybe we've missed the boat. And again, allow me to dive. This is a study we did several years ago. And this is, again, our volcano plots. And what we did, we had 15 patients with lupus nephritis. Now, this was not early lupus nephritis. This was established lupus nephritis. Their initial diagnosis is A, okay, the A side of the volcano plot. And then they were treated, they responded, and then they flared again, and that's B. So we're comparing A, the very first time they had lupus nephritis, to B when they had a flare. And what you see here is that the interferon, I'll just look at the glomeruli, the interferon transcripts are actually upregulated in A compared to B. So the first go around with lupus nephritis seems to be pushing interferon. And then when you look at B, you see a lot of TNF transcripts, but fewer elevated interferon transcripts. And so one of the questions that I have posed to the anifrolumab folks is maybe we're not targeting this correctly, because if we are entering patients into the anifrolumab trials that are flaring patients, which usually is the majority of patients that we enter into clinical trials, maybe we've missed the boat in terms of interferon as a target. So things to think about of how we should potentially target earlier, and also think about when we're hitting the disease and what is being activated at the time. And we, of course, don't know that very well by the time we do the diagnosis like we do in animals. Okay, now you're probably saying, okay, that's fine. This is a study. You're doing protocol biopsies. And if we wanted to implement this clinically, is there anything you can tell us that would suggest a patient with lupus and low levels of proteinuria should get a kidney biopsy? And my feeling is everybody should, but in lieu of not being able to do that in real life, we do have some clinical data which are correlated with the patients who had LN on these early biopsies compared to having no histologic LN. And what we see is patients who have low complement, not necessarily at the time you do the biopsy, but ever, so a history of low complement, or the patients who are anti-double-strand DNA positive, they actually seem to suggest that these patients might have histologic evidence of lupus nephritis. Maybe you're thinking the more important question, because I am too, with our data, and we have to check this, is it doesn't tell us whether this is histologically actionable lupus nephritis. So this could be class 1 and 2. So I think we have more work to do, but I think this gives you an idea of potentially where we're going with this. And, you know, using clinical biomarkers, we sort of get a hint at who might be having something going on in the kidneys. And then this is a heat map, which is impossible to read, but I summarized it here. This is the outcome of treating these subclinical classes at 1 year. So these are the class 3 patients. And basically, I'll just summarize what this is showing. The yellow is the first diagnosis when they have this little bit of proteinuria. And then because they had class 3 histology, nobody was willing to sit on that. Okay. And so you sort of get the idea that to do this study correctly, which would be, okay, we're either going to sit on this because nothing's going on clinically, or we're going to treat it and see what happens. That's a hard ask. And all my other partners in this endeavor are rheumatologists, so that's an impossible ask. The patients are going to be treated. 100% were treated with mycophenolate and without pulse steroids, because this was pretty mild disease. They had ACEs and ARBs. A lot didn't get prednisone. And then eventually half of them got a second immunosuppressive therapy, belimumab, voclosporin, and tacrolimus. It turned out that 83% of these patients were stable or improved. And you can say, well, what's improved? They started out with under 500 milligrams of proteinuria. It went less. Okay. And this next begs the next question. And Sean's been saying he measures albuminuria. We have not traditionally measured albuminuria in our GN patients, but I'm now starting to measure albuminuria in all our patients. And maybe we need to start thinking of something other than proteinuria to look at to understand these very low levels of proteinuria. So I throw that out there because we want to study that. Anyway, so just, class 3 by itself would never have an 83% sort of response rate at 1 year. And so you could say, I could say, and you could say you're wrong because you don't have a appropriate control group. I could say that if we treat early, we are going to prevent really severe disease from manifesting. And I love that idea because it just makes sense. We're going to have to show it. I'm not sure how we show it unless we randomize these people to getting treated or not getting treated. And I think that's going to be, like I said, a hard sell. And I'm going to skip this. It's very much the same thing with class 5. Okay. So point 1, diagnose and treat early to improve the outcomes. The second point is to reverse or limit intrarenal damage. And so this is a study that Anna and I did, and we published it a couple years ago. And so this was biopsy 1 of patients who were flaring lupus or new onset lupus nephritis. And then this is the old days, quote, old days, where we did another biopsy after so-called induction therapy. And in the old days, if you remember, induction therapy was high-dose cyclophosphamide or high-dose mycophenolate. And that usually occurred for the first 6 to 9 months. And then biopsies were repeated about 3 to 4 years later. And just to understand this cohort of patients, this was a cohort of about 90 patients that were followed for years, and they did really well. They did as well as any lupus cohort could possibly do. They went into remission, very few. I think 2 went on to have CKD, or 1 had end-stage kidney disease. So they did really well with treatment. But what I want to point out is that in the first 9 months, when they were getting sort of state-of-the-art therapy, which was NIH-level cyclophosphamide or high-level mycophenolate, you see that they're starting to accumulate chronic damage in spite of this high level of therapy. And so you could actually anticipate what the next point is, which is every time you have a flare, you accumulate as you're doing the best job you can do to treat the patients. Now, a good question that you might think about, and I don't really have much of an answer for you, but I'll give you what I have, is, well, do the new therapies mitigate this in any way? Are the new therapies better at this than the older therapies? So that would be really important. But it really suggests that flare prevention is a key to avoiding progressive kidney failure in patients with lupus nephritis. And I'll show you some data on that in a second. Now, you could say, okay, this sort of makes sense. We have an accelerated, but now we're treating the patient, and then the chronic damage sort of slows down a little bit. But what's going on here? This is fibrous crescents. Are there any pathologists? No, okay. So we published a paper to follow up on this because we thought this was curious. It turns out that if you look at what happens to fibrous crescents, they sort of merge into glomerulosclerosis, and they're very difficult to tell apart. And so I think that what we're seeing here is this goes down and this goes up because more is being counted as glomerulosclerosis. And in fact, a lot of us think that we need to revise, yet again, the lupus activity and chronicity indices, and, fibrous crescents may not make the cut. Just saying. Okay. So what do we know about the new drugs? So many of you know that I like to study biomarkers. Urine epidermal growth factor is produced by healthy tubules, and we all pee out a lot of urine epidermal growth factor. That's what normal tubules do. In acute injury and chronic injury, the urine EGF declines. In chronic damage, so the tubules don't recover, it doesn't get better. In acute damage, you can actually improve as the acute damage to the tubules resolves. And so we have suggested, as have others, that urine EGF is a marker of tubulointerstitial health, and the increase in urine EGF heralds the recovery of the tubulointerstitium from acute injury. So now let's move that to the Regency trial of obinutuzumab. And so we have this sort of written up, and we want to get this out to publish it. We measured serial urine EGF levels of the patients that were being treated with obinutuzumab or placebo. And as one might expect, the patients treated with obinutuzumab in this blue line here, the urine EGF gets better with time as these patients enter a complete renal response. And that shouldn't surprise you because they're getting better. And it should not surprise you that the complete renal responders in the placebo group get better. It isn't that urine EGF is special for obinutuzumab. It is telling us, I think, that the tubulointerstitium is improving. But what's really cool is, sort of like I said, when you have the placebo group and they don't get better, the urine EGF really doesn't get better. And in fact, it declines, suggesting we're losing tubules, okay, and maybe moving into chronic injury. This is really interesting. The non-complete renal responders with obinutuzumab improve their urine EGF. And so we are postulating in this paper that, in fact, this B-cell drug, for whatever reason, outside of the ability to cause a complete renal response the way we measure it traditionally, is actually providing something that improves the health of the renal tubulointerstitium, which I think is really cool. And, you know, you could say, well, are there any data for belimumab, another B-cell drug? Different, of course. It's Bliss, and you all know Bliss from the lupus, but also now from IgA nephropathy. So this is work that Anna did. She took the data. She had a bunch of repeat biopsies from the Bliss LN trial. So biopsy 1 was the biopsy to get into the trial, and then the patients were treated for 2.5 years with belimumab or control, and then they did a post hoc analysis, and then she repeated the biopsy an average of 40 months from the initial biopsy. And what you can see here is the chronicity index of patients receiving mycophenolate and the placebo compared to the chronicity index of those getting belimumab. And the scales are about the same, but you sort of get the gestalt that the chronicity index overall is increasing more in this population than the population receiving belimumab. And this is sort of the beginning and the end, the average, and this is a little bit steeper. You can say, well, that's baloney. This is pretty weeny data, and there's very few patients, but it sort of gives a suggestion that maybe something is going on that's nephroprotective from the B-cell therapies. And I'm going to give a little bit more data to that effect in just a second, clinical data. So to be fair to all the drugs that we have at our disposal, I want to talk just a little interlude about the calcineurin inhibitors and then get back to the B-cell drugs in terms of nephroprotection. So we all use and are happy with calcineurin inhibitors in our daily practices, and you all know that they do things to the podocyte and to GFR that is relevant to what we see in terms of proteinuria. And that's all true, and that has nothing to do with their immunologic activity relevant to lupus, which is really involving the T cell. I love this experiment. I show this to my rheumatology friends because I think they need to understand what calcineurin inhibitors do. And this is tacrolimus. This is the MRL-LPR mouse model. And what this is showing is that in the disease control, so these are the MRL-LPR mice, after several weeks of having the disease, they develop the disease spontaneously, you get complete foot process fusion, which we all understand and expect. If you treat prior to sacrifice the mice for 8 weeks with tacrolimus, look at the preservation of the podocytes. It's remarkable in these lupus nephritis mice, and presumably the same thing can happen in patients. So obviously, you know that if we damage the podocyte, and effacement is damage that's reversible. Loss of podocytes, of course, is potentially irreversible unless we really do have conversion of maybe the parietal epithelial cells or that initial portion of the epithelial cells in the proximal tubule, filling in the gap. Usually you lose podocytes, you've lost them, you get glomerulosclerosis and chronic damage to the glomerulus. The other thing is that the calcineurin inhibitors do is rapid control of proteinuria. This is time to a 50% reduction in proteinuria from the voclosporin trials in lupus nephritis. And you can see that literally within a couple weeks, you have this profoundly higher decrease in proteinuria. No surprise to anyone here, this is almost certainly not immunologically based, but does it matter? Because proteinuria in and of itself is toxic to the kidney. And I chose here this sort of schematic or diagram of looking at all of the tubulointerstitial effects of non-specific proteinuria going through the tubules. And so this is the lumen side, this is the blood side, and the interstitial side. But we know that as this goes through, the proteins carry a lot of things that may be toxic to the tubules. We know that complement can be activated within the tubules and complement components can be activated. We know that reabsorption of protein as well as complement acting on the tubular cells can set off programs that are pro-inflammatory to cause tubulointerstitial nephritis and profibrotic. So to me, it's very clear that preventing or stopping or reducing proteinuria is a goal in and of itself, despite or in addition to it being a marker of how well we're doing in treating the disease. And of course, it's a biomarker for all our diseases, not a very good one, but a biomarker of all our diseases. Okay, preventing flares. Repeated lupus nephritis flares really associate with a lower response rates and lead to progressive loss of kidney function. And this is work from Juan's group, and Juan got to spend some time with me in the labs a few years ago. The first flare is the reference, and then you see the second flare and third flare in terms of treatment and complete responses and partial responses. And you can see that compared to the reference, by the time you're at the third flare, people are not responding very well to the therapy you're giving them, either complete or partial. And this is a graph over time showing the patients free from doubling of serum creatinine. And it's pretty clear that as you have more and more flares, your tendency will be to have loss of kidney function, and those patients are at risk for chronic kidney disease, et cetera. And so we can say, well, can we mitigate that? And that's all with old standard of care therapies. I call them old, but standard of care therapies, which is mycophenolate or cyclophosphamide plus glucocorticoid. These are the data from a post hoc analysis we did of the BLISS-LN trial. And this is flares in the BLISS-LN trial. And it was really, if you remember, the BLISS-LN was the very first trial where we did a 2-year study. So we could actually look at flare rates of lupus nephritis. And what you see here is no matter what the background therapy was that you added to belimumab, or what the class was, 3, 4, or 5, or mixed, there were fewer flares in the patients receiving belimumab. And I thought that was amazing. What is belimumab doing to prevent flares? And then we did the same sort of, this was sort of an experimental or a exploratory analysis of the time to flare from week 24 through week 76 in the Regency trial with obinutuzumab. And just to say it right up front, there were not a lot of LN flares in this trial, but you can see that the hazard ratio was about half in the patients being treated with obinutuzumab. So now we have two drugs that affect B cells in different ways that seem to actually decrease the tendency of lupus nephritis to flare. So I think that's really important. And again, to be fair, look at all the data. We did look at flares in patients being treated with voclosporin. And you can see that the flare rate is absolutely identical in that group. So I would suggest to you that we are now differentiating these drugs, at least in what other things they do beyond complete renal response. And I think that's a really important concept, because complete renal response is an artificial construct that we have created to make us feel good and that we're doing something good for the patient, but there's a lot of other things that these drugs do that actually may benefit the kidney. So I want you to keep that in mind. Okay, this is really a fun study that I did with Genentech, and we analyzed from the electronic health record of 118 million patients. We analyzed over 3,000 patients who had incident lupus nephritis, so a brand new diagnosis of lupus nephritis. And it turned out in that population, complete renal response occurred in about half of the cohort. And we'll come back to that concept in a minute. But this is the time to first flare for patients who had either a complete renal response or no renal response. And you can see here that even with this artificial construct, which is generally getting to a proteinuria level below 500 milligrams a day, keeping the GFR within 80% of what you started, you can see that you don't prevent flares, but you delay the time to flares. And so I would suggest to you that, and this is by and large, the time frame does not include the new drugs. Okay, this includes mycophenolate, cyclophosphamide high dose, and cyclophosphamide low dose urolupus. Using our standard of care therapies, we can prevent flares, or at least put them off in patients if we can achieve a complete renal response. So now I'm going to ask the biggest elephant question in the room. With all this novel therapy that we have out there, how are we actually doing? Do we ever sit back and grade ourselves? And I would suggest we're not doing very well. This is the voclosporin trial. 43.7% had a complete renal response by the definition I just told you. Belimumab at 2 years, 30%. Obinutuzumab at 18 months, 46%. We are not even getting a complete renal response in 50% of the patients we're treating with the addition of these new drugs to our regimen. Okay. I took all the data from the older trials, okay? The ones I grew up with, the LUNAR, the BELONG, the EuroLupus trial, and you can see here that this is high-dose mycophenolate, EuroLupus cyclophosphamide, high-dose cyclophosphamide. We don't reach 50% in those trials either. And in fact, if you look at mycophenolate, the 1-year complete renal response is about 35% if you add all these trials up, and about the same for cyclophosphamide. Not very different from all these new really expensive drugs. Now, that doesn't mean the new really expensive drugs are not doing things, because I've just shown you that complete renal response may not be everything that we want. The new drugs, I believe, add certain things to our care of the patient with lupus. Maybe they benefit the tubular interstitium. Maybe they prevent flares. A lot of the B cell drugs especially tend to preserve GFR over time. So there are benefits from these drugs that are not revealed in the complete renal response rate. And you have to think about these sorts of things when you're treating the patients. This is the effect from the same study I showed you with the 3,000 incident patients. This is the effect of complete renal response and long-term kidney survival. And the unfavorable kidney outcome is defined as doubling of serum creatinine, et cetera, CKD, ESKD. And what you see here is if you never achieve this sort of thing we made up called complete renal response, you don't do very well. Okay, the kidneys are not going to survive over time. If you do pretty well. The kidneys still are subject to getting into trouble. And if you do get a renal response at least once, so this is sustained renal response and this is unsustained complete renal response. So it suggests that if we can at least get patients to that complete renal response sometime during the course of treatment, we're benefiting their kidneys, but it's not perfect. Okay, so now let's go for perfect. Targeting deep tissue depletion of B cells. So this is the newest, hottest thing in autoimmunity and lupus nephritis and lupus. In 2022, everything changed. For the first time, we were shown a therapy that resulted in more than an incremental change in the complete renal response rates. And I'm talking about the CAR T cell or cell therapies. And this started the conversation. And I think this conversation is a bit premature using the word cure. And we'll talk about why, but it started that conversation. And this is very exciting stuff. Uh-oh. Did it change? Oh. Oh, there. These were the two trials, and this is from George Schett's group in Germany. 5 refractory lupus nephritis patients treated with CAR T. All of them went into remission within a few months and had minimal adverse events. Maybe not what we're seeing right now, but this is really interesting. Wait, let me. There. This is the. We already saw the punchline. The 2 years, they published the follow-up of those 5 patients plus 3 more. 100% of these LN patients had achieved complete renal response in 3 months of CAR T therapy, no lupus nephritis relapses, off all immunosuppression, including antimalarials. Let that sink in. That's unbelievable. I haven't shown you anything that's achieved that with all of the fancy new things we're doing. Okay, now this is the punchline. Newsflash. They're reporting the 4 and 5 year results of these original patients, and up to 4 and 5 years, these patients have not had recurrent lupus nephritis. This is unprecedented in my opinion. Okay, so these are amazing results. I think you'll agree with me, and I don't understand them. So I decided the best way to understand them is to compare with our very best B-cell drug, obinutuzumab, to the anti-CD19 CAR T-cell therapy. Okay, so this is what I want to try and show you. And then I'll tell you what I think we should do going down the line. So this is cell therapy. This is the protein creatinine ratio. And you see that by month 3, almost none of the patients have proteinuria anymore. Now, we're all nephrologists. There may be rheumatologists online. If you have refractory lupus nephritis, it's truly refractory. To me, that means you've had lupus nephritis for a long time, and you've been treated with lots of things, and you haven't gotten better, and you should have developed scar. And I don't understand why scar proteinuria goes away with this therapy. So I know George Schett, and he's a great guy. And he said, well, maybe their lupus nephritis wasn't so bad. These were the original patients. And we now know that in the trials that are ongoing, we are not seeing all of the patients go to 0 proteinuria. And that's okay. It's absolutely okay if the activity of the disease is turned off and you have some residual proteinuria. We have drugs for that. We have SGLT2s, GLP-1s. We know how to take care of residual chronic kidney disease. So this is a little bit of the best, but it's still really cool. And you can see that this is obinutuzumab, and you can see that the proteinuria decreases, but it's much slower. This is much more what we're used to seeing in our day-to-day practice. We get there, but it takes longer. Okay. CAR-T and obinutuzumab result in deep peripheral B-cell depletion. The word is peripheral. How do we measure B-cell depletion? Flow cytometry from a blood test. And this, I'm foreshadowing, good authors foreshadow in mystery novels. That's not enough, okay, the periphery. Look at the B cells, the CD19 B cells in all the patients treated with CAR-T are gone within a few days. And look at obinutuzumab. By 4 weeks, all the peripheral B cells are gone. Okay, what if we measured it back it up? Because this is the first time we measured it. Well, I measure flow in a lot of my OB patients, and it's gone within a week, 2 weeks. Okay, so I would say we get similar peripheral results. The B cells with obinutuzumab don't come back for a long time. The B cells in the patients treated with CAR-T, the solid lines, are coming back in almost all the patients by 3 months or earlier. It's a very short-lived peripheral B-cell depletion. And you could say, well, this seems better. Why is this happening? And so try to answer that question for you. It turns out that what comes back may be really important. And so what's coming back at 3 to 4 months in the CAR-T is the naive B cells are repopulating. Naive meaning hopefully no autoimmune memory, versus the memory B cells are not really coming back. And you say, okay, that must be the difference for CAR-T versus obinutuzumab. Well, it isn't, because if you look, this is the last time the obinutuzumab dose was given. Memory B cells are not coming back. And you see what comes back after the last OB was given at 6 months. At 52 weeks, the naive B cells are coming back. So OB looks a lot like CAR-T cell with a longer peripheral B cell depletion. Why aren't the results of OB the same? And so I think tissue is the issue. And those of you who know me very well know that I like to do biopsies and more biopsies and lots of biopsies. And once I was challenged at a rheumatology conference, I had to have an innovative idea. And my innovative idea was that every human being with lupus actually probably has renal injury. And I think now the early data that I showed you suggests that I was right. Do we have to treat that? We'll find out. Okay, so cell therapy depletes B cells from the kidney. This is 30 days after cell therapy. This is a repeat biopsy. You see CD20 cells are gone, CD19 cells are gone from the kidney. I make an unsmiley face here because they didn't do a pre-biopsy to look at the B cell levels in the tissue, and I'm going to show you what B cell levels in the tissue look like in real life. Macrophages and T cells still remain. So what we expect with something wiping out tissue B cells. The same thing happens with obinutuzumab. These are data I presented at the ASN. Again, we're working on writing this up, but the B cells are stained green, CD79, that's obinutuzumab. Plasma cells and plasmablasts, I'm going to use the word antigen-presenting cells or antibody-producing cells, are stained in red. The red also, unfortunately, stains the renal tubules, but you can tell tubules versus cells. And you see here that these 3 patients had a lot of B cells in their kidney, and they're gone at week 76 when we did repeat biopsies. We did 62 repeat biopsies in the obinutuzumab trial, 30 in the one group and 30 in the placebo group. And you can see that the B cells remain in the placebo group. Now, you could say, well, Rovin, you picked the very best pictures. I didn't pick the very best pictures. Genentech picked the very best pictures. I said, we can't use simply the very best pictures, because look at what the B cell counts are in patients who have active lupus nephritis. Those are those people. Some of those people don't have any B cells in their kidney. If I was sitting in the audience, I would say, do those people actually respond to obinutuzumab? Do you need B cells in your kidney to respond? I don't know the answer to that because we want to look at it, but it's sort of a cool question if you actually can start to think about what's on the kidney tissue and then decide what therapy to use. In a lupus patient that doesn't have much of a B cell infiltrate in the kidney, maybe we don't want to use a B cell drug. Maybe we want to use a T cell drug. Maybe we want to use anifrolumab or an interferon drug or one of the other drugs. Okay, but you can clearly see that mostly this goes to 0 B cells in the kidney. This is the placebo group, and you don't see much of a change at all. In fact, it actually increases a little bit. And then we also measured antibody producing cells, and they actually decline in obinutuzumab and don't decline in placebo. I think what you're seeing here is that in the antibody producing cells that are short-lived plasmablasts, they need replenishment of B cells, and OB prevents that, so these decline, but it doesn't go to 0. Okay, this is really an important concept. Okay, and I'll finish up. Cell therapy depletes B cells in the peripheral lymph nodes as well. So this is obinutuzumab, bilatutumab, which is one of the T-cell engagers. So let's just forget that one. So this is OB, rituximab, and CAR-T. After obinutuzumab, you see a pretty good depletion of B cells in the peripheral lymphoid tissue, but you see nothing left in the CAR-T. And you see now how much better entering the tissue is with obinutuzumab compared to rituximab. And we sort of knew that from cancer because OB is a better cancer agent at cleaning out the residual malignant cells than rituximab. Okay, this is really cool too. The CAR T cells blow away the germinal centers. So this is an H&E, and you can see the germinal centers, and you can see that pre-CAR T, there's a lot of follicular dendritic cells and PD-1 or positive cells that are T follicular helper cells, and after CAR T, they're gone. I mean, it's just like a nuclear explosion in the peripheral tissue, and this is after obinutuzumab. It still remains. The germinal centers still remain. So now we're starting to differentiate the effects of the CAR T cell versus the B cell. And now I'm almost done. Are we targeting with our B cell drugs the correct B cell? Remember, the CAR T are killing CD19 positive B cells. OB, Ritux, are targeting CD20. CD20 is expressed on these B cells. CD19 is expressed on all these B cells except for the CD19 plasma cell, which is usually found as it shed everything deep in the niches of the bone marrow. And it may be relevant. We can target it with BCMA cell therapies, but look at all the B cells that are targeted by CD19. And the story goes, I don't know if this is true or not, but I did ask my friends at Genentech. Genentech had an anti-CD19 and an anti-CD20, which turned out to be rituximab. And they did sort of a coin toss to decide what they would bring forward to the community. And they chose CD20. Maybe they should have chosen CD19. And this is from George Schett's group. You get complete 100% CD19 B cell reduction in patients that have CAR T. You don't get very good in rituximab. You get much better with obinutuzumab, but not complete. Some of us are now thinking that what we should really be targeting with monoclonal antibodies to achieve results that may push towards what we see with CAR T without the involvement of hospitalization, harvesting the bone marrow, adenoviral transformation of the patient's T cells, reinfusion, the risk of cytokine release syndrome, the risk of the ICANS, which is the neurologic cytokine release syndrome, we might be able to push things along very nicely with an anti-CD19 monoclonal antibody, and then reserve the CAR T cells for those few patients that really, really need it. And that would be ideal, is we step up therapies, but only the most severe therapy, severe in the sense of what has to be done, would be for only a few patients. Okay, last slide, and then we can do questions. All right, to improve kidney outcomes in lupus nephritis, diagnose early, reconsider when to perform a diagnostic biopsy, treat early to achieve an early response, be mindful that lupus nephritis evolves over time, and therapies that might work well for de novo lupus nephritis might not work well for flaring lupus nephritis. The triple therapy regimens that we have now offer unique benefits that go beyond simply CRR, preservation of podocytes, preservation of tubules, decreasing kidney damage, preventing flares. And that might actually be something that I think that's something we need to do. And we do use the triple therapies in our own practice. Accumulating evidence suggests we have good long-term kidney outcomes by deep tissue B cell depletion of B cells. It's too early to call this a cure. We have to have more time. But I think, again, we may be targeting the wrong B cell with our monoclonal antibodies. So thank you. And I'm happy to take questions. That was a great. Of course.
Thank you, Brad. That was a great talk. Very provocative. A lot of things to think about. Just going back to the original data you had at the beginning about subclinical LN. So I'm trying to think about how we would actually operationalize that and what the implications would be. So many people would not necessarily treat class 5 disease with less than 0.5 grams a day of protein. Not all class 3 invokes the same level of urgency to treat. If you look at the activity index and you have a wire loop or you have a hyaline thrombus and that's it, you get a class 3 designation versus a whole bunch of hypercellularity. And yet, in class 2, we traditionally don't treat at all. And yet the chronicity levels are not unsubstantial in your data. So I guess the question is, should we be looking at the long-term outcomes of patients with class 2 or mild class 3 to see, like, maybe if you follow enough people long enough, the chronicity matters? I mean, how could it not matter long-term? And should we be thinking about modified treatments where we don't invoke the same level of toxicity, because we know our lupus patients have substantial comorbidities from the immunosuppression burden they get, but maybe they don't need that level, because otherwise we could end up biopsying a lot of people and not necessarily action on a lot of it, but yet still have chronicity levels that might increase over time.
Yes. So yes, this is great. So we have a class 2 paper that's being reviewed right now. We did transcriptomics on the class 2 patients, and what we're seeing is much more inflammatory cytokine activity than one would predict looking at the tissue. And we see a huge fibroblast signature, suggesting that even in class 2, things are moving in a direction of having damage. So I think that we have sort of made these rules. I didn't make them. I mean, well before my time. Class 2, don't do anything. Class 5, leave it alone unless it's nephrotic range proteinuria, and then decide what to do by 3 or 4, depending on what the tissue looks like. And I think that to answer your question is, we need to understand what really is underlying what we're seeing in the kidney tissue. And I would suggest to you that what we see that may be mild may actually, at the transcriptional level, be really hot, and it should be turned off. Now, your question is more important or more involved than that, which is, if we start doing that, are we going to overtreat a lot of our patients? And I would guess the answer is yes. I would guess that if we see a really mild-ish class 3 and we pile all these drugs on, we're overdoing it potentially, okay? And so to me, we need to know how to better treat the individual patient, not the group of patients that we get from a clinical trial. And the other thing that I think we need to do is to understand what is actually going on in the tissue. And if we intervene early, for example, if we have a class, I would love to do this experiment. If we have a class 3 that looks sort of wimpy histologically, it's really early and not a lot of proteinuria, but the interferon signature is off the wall. What if we just give a little bit of anifrolumab and we don't give mycophenolate and we don't give high dose glucocorticoids and we don't give a B cell drug? So what I'm hoping is that these sort of ideas are going to provoke us into trying to use the biopsy, not just for diagnosis and prognosis, but to start to push us what pathways could be targeted early on to prevent the need for this excessive amount of immunosuppression and all its comorbidities. Absolutely agree with you.
So tangential to that, but like also with the class 2s, we're talking about immunotherapy, but knowing that our SGLT2s and non-steroidal MRAs and GLP-1s have anti-inflammatory effects, that would be an interesting design, right? Immunosuppress with a little bit versus current disease-modifying therapies with less toxicity. And I think that's something that as general nephrologists, we haven't yet got our head around. Oh, it's a class 2, I won't treat the lupus, but are we actually then switching and making sure that we treat them with the other disease modifying agents?
So that's a great question. All these SGLT2 studies are now showing, again, at the transcriptional level, that they do mitigate inflammatory foci in lots of places, not just the kidney, obviously. And so you're the second person who has suggested we do a trial of this in our lupus patients. So there's a lot of interest brewing in this now. Can we do something mild I call it immunomodulation, with things that are not necessarily big time immunosuppressive agents? And could that benefit the patients? And I think the answer is probably yes. We're going to have to choose the patients carefully. And I think despite everybody's hesitancy to do biopsies, we have to biopsy and then do a repeat biopsy to see what we're actually doing. And I hope I convinced you and the people in the audience, there's a bunch, and the people who are rheumatologists, that patients are okay with doing a repeat biopsy if you ask them and tell them why you're doing it. The people who are resistant to doing a repeat biopsy or a biopsy at all are us. We don't want to do it for whatever reason. And I think that many of our patients, I showed you that 62 patients out of the however many, 300, that's a lot of patients. And, by having serial biopsies, you get a lot of information. So I'm putting a plug into that. And I will tell you that currently in all of the CAR-T trials that I'm involved in helping, we are putting in a repeat biopsy cohort. It's optional. We don't want to force a person to have, obviously, an invasive procedure, but we're asking patients if they would do it. And, patients are saying, a lot of the young folks who are doing this, well, if I'm going through all this terrible thing anyway, having a biopsy is not a big deal. That's the easiest part of getting a CAR-T therapy. And so they are getting this. So we're getting a wealth of information that I think will be, to your point, useful. But I hope what you took away from this is, we're not doing really well right now. We have interesting therapies that may do something better, but we also have existing therapies, to me, that we're not using properly. We have B cell, T cell therapies, and we're still piling that all on top of mycophenolate. Did you ever take your lupus patient off mycophenolate? I take them off all the time. They feel much better. Mycophenolate, great drug, even if they're not having nausea and vomiting. When you take them off mycophenolate, they feel fabulous. Makes them feel crummy and tired and this and that. It's hard to tell from lupus what the symptoms are. So I think one of the trials we're doing, investigator initiated, is an arm where we give Voclo, belimumab, and MMF. Everybody gets it. At 3 months, one of the arms, MMF, is taken away. Do we need to continue these sort of broad spectrum, highly adverse event drugs? And my guess is probably not. But we have to show that. And people are just uncomfortable. I wanted the arm to be 2 new drugs and versus MMF. And the sponsor said nobody's going to enroll a patient unless they get treated with MMF. I said, well, I would. But anyway, I think the point is we should be more creative with these drugs now that we have them. And the only way we're going to get to do this is through investigator-initiated trials, because no company wants to rock the boat if their drug is approved. But I think we can do these sorts of things through however we get funding. And it's really important to understand how to use the new drugs appropriately. And I don't think we're using them to the best advantage.
Thanks. I think you're also making a plug for basket trials so that we can actually understand these, like with this, starting a new trial from scratch every single time is like, we just need a different kind of platform so we can enroll patients and figure out right person, right drug, right time. This is very cumbersome to do it this way.
Yeah, the whole clinical trial scene is going to be changing. You all know, you're all nephrologists, IgA. How can you do a trial with a placebo arm nowadays when you know you have drugs that work? And each country has a different sort of thing now, so it makes it very difficult to figure out how to do trials going forward. The same thing with lupus. So we have to think about new ways to do this. The FDA, the CAR T trials are actually being done as single arm now, by the way.
Yeah.
How, I don't know, but everybody is scrambling to find a historical cohort that they can match the CAR T against. And the problem with that is there are no historical controls of refractory lupus nephritis to match the CAR T against. So, and we actually discussed this with the FDA. I don't know if anyone here, and it was an NKF sponsored meeting, could we use historical controls uniformly for IgA trials? And the answer was not really. So I think we have to move in that sort of direction. So for sure.
So we're over time, but
of course, I'm always over time.
Always over time. But anyways, it was a really stimulating way to start a Friday morning in July. Thank you very, very much for taking the time to come, but also for a really thoughtful and thought-provoking. And I think these are the sorts of conversations we can have in clinical venues as well, and at biopsy rounds and other places to see how we can optimize the care of patients. So thanks to Dr. Rovin and to all of you for participating. There were 74 people online, so that makes almost 100 people for a Friday morning in July, which is pretty terrific. So thanks again, everybody, and thanks to Dr. Rovin.